I think everything that we described, again, these inflammatory, cell death pathways, again, are really key in low risk MDS. They're still active in high risk, but if you look at, for example, the magnitude of activation of many of these IL-1 beta levels, NLRP3 activation, caspase-1 activation, they're all dramatically higher in low risk MDS versus higher risk MDS. Again, I think higher risk MDS, you're really going to have to fall on novel HMA combinations, venetoclax, again, targeting, BCL2, et cetera. And again, somewhat shares more maybe pathophysiology even with AML patients. And I think that even goes to now this sort of MDS AML category of 10 to 19% blast, because for many molecular subsets, there's a high degree of overlap between those group of patients. I think the one thing to maybe comment on is maybe to go the other way. So I think we know that there is this pre-MDS state of CHIP or clonal hematopoiesis, or CCUS, which is clonal cytopenia of undetermined significance. And we know some patients are high risk. So if they have multiple mutations, high allele frequency of mutations, these patients actually have a pretty high frequency of ultimately developing disease. And there's already data supporting that these inflammatory pathways are quite. So probably the CCUS overlaps more with the low risk MDS. And could we think about these strategies? So for example, Dr. Barate at OHSU does have a trial with that canakinumab agent specifically for high risk CCUS. Dr. Zoe Zia, my institution, has some interesting concepts for TET2 mutant patients, for example, with IV vitamin C. And then maybe some other combinations that may go into this inflammatory path. So I think that group, I would think CCUS and low risk MDS. I think high risk, really think about these HMA combinations. And although these may be important, I think have less likelihood of having real clinical benefit in the high risk setting.